Hi, good day to everyone. Hope everyone is fine. My name is Aun. I'm an upper GI gastrointestinal and bariatric surgeon from Singapore. First, on behalf of Ifso, I would like to welcome all of you to this 23rd Ifso Journal Club. It is my great honor and pleasure to moderate today's Journal Club. The title of the article chosen is All-Cause Mortality of Patients with and Without Diabetes Following Bariatric Surgery, Comparison to Non-Surgical Matched Patients. This article was recently published in October issue of Obesity Surgery, the official journal of Ifso. Today, we have invited authors of the article, Dr. Dicker and Dr. Regis, to present their study. Before starting the presentations, I would like to remind all of you that the webinar will be recorded and archived, and Ifso will make it available for offline viewing in the Ifso Virtual Academy for Ifso members and Ifso YouTube channel from tomorrow onwards for those non-members who couldn't join us today. After the presentation, there will be Q&A sessions, and you can also type in the questions, and I will ask the authors on behalf for all of you for the discussion. There will be some poll questions later as well, and I would like to invite all of you to join us by responding the polls too. So shall we launch the first two polls? Thank you. Okay, may I see the results? Still in progress. Wow, that's fantastic. We have 70% Ifso members and 30% non-Ifso members. So I welcome all of you, both members and non-members, to today's Journal Club. Okay, maybe we can go for second poll. Well, we have 78% surgeon and 22% integrated healthcare professionals. Thank you. So without further ado, I would like to introduce our presenters, Dr. Draw Dicker. Dr. Draw Dicker is a professor of internal medicine department, Hasharon Hospital, Rabin Medical Center, Petah Tikva, Israel Secular School of Medicine, Tel Aviv University, Israel. And Dr. Honor Regis was joining us today as well. Dr. Regis is an epidemiologist at the Claret Research Institute and currently a postdoc research fellow at Northwestern University under the Department of Preventive Medicines, Chicago, USA. So Dr. Dicker and Dr. Regis, good day to you. Nice meeting both of you online again, and congratulations again for your work. So please share your slide with the audience for the presentation. Thank you very much.
Hello, Professor Mint. In the name of mine and Dr. Regis, I want to thank you and the Ifso leadership choosing our paper to be presented. It's a great honor for us. So our paper entitled as All-Cause Mortality of Patients with and Without Diabetes Following Bariatric Surgery, Comparison of Non-Surgical Matched Patients. So we know that bariatric surgery has a tremendous metabolic effect. And in fact, in this study by Cummings and Rubino, they showed us that bariatric or metabolic surgery had very good and important and significant effect on remission of diabetes. In all these 11 papers, and today there is 13 papers that shows that above the BMI of 30, there is remarkable effect on remission of diabetes, which is due to bariatric or metabolic surgery. So bariatric surgery bring to a better metabolic effect. And we also know that bariatric surgery has effect on mortality. From this very important study, the SOS study, we see that after 15 years, there is 24% reduction in all-cause mortality. We have to recall that the SOS included 18% of bending, 69% of VBG, and only 30% of Roux-en-Y. But again, we see a tremendous effect, a very impressive effect, reducing of mortality, comparing surgery to control. Now, in a very recently published paper, again from the SOS, now after 23 years, we can see that even after 23 years, there is effect of 23% reduction in all-cause mortality. So in the SOS study, we saw that there is reduction of mortality, but we know that from the SOS, only 10% in the first paper and 17% in the second paper had diabetes. The majority of the patients were not diabetic patients. So if we want to compare the effect of bariatric surgery on mortality in diabetic patients, we can really relate to this paper that compare in the laparoscopic gastric bending after 20 years follow-up, diabetic patient who had been had surgery, bariatric surgery by the laparoscopic gastric bending, to non-surgery diabetic patient. And again, here we see a very impressive 48% hazard ratio reduction in mortality. We can also see that in this retrospective analysis by Eminem, who compare really metabolic surgery of diabetic patient to a non-surgical control. Again, now it's the two groups are diabetic patient. So this is the non-surgical diabetic patient, and this is the surgical diabetic patient. Again, we can see here a 41% reduction in total mortality. In this retrospective analysis, they involve 63% of Roux-en-Y gastric bending and 33% of sleeve gastrectomy. So we have the band, we have the Roux-en-Y, and we have the sleeve in different papers that shows that if we compare diabetic patient surgery compared to non-surgery, there is reduction of mortality. So the aim of our paper was to investigate the association of bariatric surgery compared with usual care on all-cause mortality in individuals who underwent surgery and match control stratified by the presence of diabetes. In other words, we want to really compare the effect of bariatric surgery on diabetic patients that were match controlled to non-surgery diabetic patients and on non-diabetic patients that were match controlled to non-diabetic patients who didn't have surgery. So this study was not done before. So to understand the study design, I want to ask my co-author, Dr. Reges, to really explain us, to show us the method part of the study. Please, Dr. Reges.
Thank you. So this slide, in this slide, we can see the study design. So this was a retrospective cohort study that included Clalit patients who underwent bariatric surgery over a period of 10 years. And for each individual, the index date was defined as the date of the bariatric surgery. 3 matched non-surgical patients were selected for each surgical patient, and for each participant, we extracted baseline demographic and clinical characteristics from the Xxiii data warehouse during the 3 years prior that index date. And we completed the follow-up for all participants at the end of 2015. Next, please. Next, though. Okay, next. I saw all this issue. So the surgical patient were matched to obese non-surgical patients. No, Dor, can you get back to the previous one? Yes. So the surgical patients were matched to the non-surgical patients who received only usual care, which is provided by the primary care physician, and it may include the dietary consulting and behavior modification. Matching was based on age. Groups on age, we used groups for the stratified for the matching by 5 years intervals. Sex, BMI group stratified by 5 unit intervals and by diagnosis of diabetes. And since baseline characteristics and bariatric surgery status for the non-surgical patients may change over time, we use what we call a sequential or time-dependent analysis. Next, please. So what is a sequential analysis? So basically this method tries to simulate the process of recruiting participants for clinical research. So let's say that the first patient underwent surgery on January 1st, 2005. So for this patient, we created a set of potential non-surgical patients who met the criteria for matching at this specific day, and chose 3 of them. So these 3 non-surgical patients on January 1st, 2005 may include a patient or patients that underwent bariatric surgery after this date, and we can see it in the Xxiii data warehouse. So basically, similar to randomized clinical trial, potential matches were selected irrespective for their future bariatric surgery status. Next, please. We define diagnosis and duration of diabetes as of index date based on Xxiii Research Institute algorithm, which incorporated hemoglobin A1C levels, glucose levels, relevant ICD-9 diagnosis codes, and diabetes medications. Next, please. We included the 3 main types of bariatric surgery. Those who had repeated bariatric surgery during the follow-up period were classified based on their surgery at the index date. Follow-up was from index date until death, and non-surgical patients who underwent bariatric surgery during the follow-up period were censored at the time of the surgery, and the minimum follow-up period was 1 year. Next. Patients were excluded from the study if they met 1 or more of the following criteria: missing BMI measurement during the baseline period, or if their BMI value were equal or less than 13 in all BMI measurements during the baseline period, the 3 years before index date, pregnancy during the 4 years period, or during the 4 years before the index date, documentation of severe comorbidities during the baseline period. Next. So for the statistical analysis, we use the stratified Cox proportional hazard regression. We used unadjusted models, adjusted. We stratified the models based on the diabetes status, and we imputed for all missing data. Next, please. And the main outcome was all-cause mortality, and it's very important to emphasize that there was no loss of follow-up for this outcome. We have all the information, and there was no loss of follow-up. Thank you. The result.
Yeah. So thank you, Dr. Regas. So I will move to the results. So as Dr. Regas said, we used the Clalit data warehouse, and we had 33,549 patients. From those 33,549 patients, 9,564 were diabetic, 2,391 had bariatric surgery, and 7,173 did not have bariatric surgery. We compare them to the non-diabetic cohort, which include 23,976 patients. From this cohort, 5,994 had bariatric surgery, and 17,982 did not have. And the median follow-up was 4.2 years. So the baseline characteristics in this table, we can see some very interesting element. So regarding the surgeries, we can see that there was preference to operate diabetic patient by laparoscopic sleeve gastrectomy and gastric bypass compared to band in the non-diabetic patient. So we have 46% of sleeve and 22% of gastric bypass in diabetic patient compared to 37 and 14.4% respectively. And in the lab, in the band, we can see that 47 or 48% were in the non-diabetic compared to only 32% in the diabetes. And we can see this trend also in other studies. Second point is that the patients in the diabetic arm were older compared to the non-diabetic arm, 53 years of old compared to 43, and we will discuss it later. And the third point is that the diabetic patients were in early diabetes, meaning they have 4.9, 4.7 years of diabetes, which is early diabetes. And we can see also that the hemoglobin A1C was in the level of 7.5, 7.2. This is a low level of hemoglobin A1C, representing the early stage of diabetes. Now, if you want to look on the weight loss indices, you can see here, and this is the BMI percent of weight loss, that in the band, 8% compared to 2% of BMI in the sleeve, 10% compared to 1.5% weight loss, and in the Roux-en-Y, 9% compared to 2% BMI units in the diabetic arm. In the non-diabetic arm, we can see the band 8% of BMI compared to 0.5% of unit of BMI. In the sleeve, 11% reduction in BMI unit compared to 0.5% in the non-surgical group. And in the Roux-en-Y group, 10% weight loss of unit of BMI compared to 0.6% in the non-surgery group. And clearly we can see that the operation, the bariatric surgery, bring a very impressive weight loss compared to the non-operated group. Now, the main result was to compare the effectiveness of the bariatric surgery on mortality. And if we look on the red line, which resembles the non-surgical diabetic patient, compared to the dotted red line, which resemble the surgical diabetic patient, we clearly see that there is reduction, impressive reduction of mortality when we compare the surgical diabetic patient to the non-surgical diabetic patient in the band. You can see the same trend in the sleeve, and you can see the same trend in the bypass, in the Roux-en-Y gastric bypass, that the bariatric surgery reduce the mortality very effectively in the diabetic patient. But we can also acknowledge that in the non-diabetic patient, the difference in mortality between the surgery group and the non-surgery group was not really significant. Now, I think if we look on the total effect in the diabetic group compared to the non-diabetic group, the surgical patient, non-surgical patient, we can clearly see that the non-surgical patient had much higher risks, more than double high risk of mortality compared to the operated group. And it was also significant in the non-diabetic. When we compare the non-surgical patient, the risk of mortality in the non-surgical patient compared to the surgical patient. Now, when we calculated the effect on when we adjusted the effect of the duration of diabetes, we didn't see change in the effect, meaning that the duration of diabetes in this cohort did not affect of the reduction in mortality compared to the non-surgical group. Now, it was very clearly that if we take the total effect in the non-diabetic patient, that we can see that the bariatric surgery reduced the risk of mortality. We can see the same effect, which was more pronounced in the diabetic patient. In the total group, okay, you can see that the operated patients had much lower risk of mortality than the non-operated patients. But if we look on the different surgeries, meaning band, Roux-en-Y, and sleeve gastrectomy, you can see that in the diabetic patient, all the surgery reduced mortality. Those who were on the band, on the Roux-en-Y, or the sleeve had much less chance to die after the operation. But we didn't see this trend in the non-diabetic patient. The only significant results were those who were operated by the band. The Roux-en-Y and the sleeve gastrectomy were not significant, so meaning that there was not significant difference between those who were operated to those who didn't been operated. Another thing that we want to see is the effect of diabetic and mortality, or diabetic and surgery on mortality. And we calculated the additional risk of death. So the additional incidence of death per 1,000 person years among non-surgical compared to surgical patients was that those who didn't have the surgery had 3.79 higher risk, or 3.79 cases of death per 10,000 person years compared to those who were operated with diabetes, and 1.09 cases of mortality per 1,000 person year in those who didn't have diabetes compared to those who didn't have diabetes and were operated. If we divided it by the different surgeries, so we see that higher 3.7 cases of mortality compared to 1.2 cases of mortality in the band, 5.4 additional cases of mortality per 1,000 person years in those who didn't were operated and were diabetic, compared to 1.6 case of mortality per 1,000 person year in those non-diabetic that weren't operated, compared to those who have been operated in Roux-en-Y, and 2.7 compared to 0.48 in the sleep. Meaning that if we take the whole picture, if you were being operated, especially if you were diabetic, you really had less chance to die than if you didn't. So if you want to really discuss the results, we want to ask why survival advantage was greater among diabetic subjects than non-diabetic subjects. So the first explanation is the time effect. If we go back again and look on the SOS studies, just to remind you that there were only 10 to 17% of diabetic patients. But if you look on all the cohorts, you can clearly see that the separation of the lines are much later than 4.2 years. And it's around 11 years here in this publication and much later here. Meaning if you take the line of 4.2 years here and here, you won't expect to see separation in non-diabetic cohorts. Very recently, the Scandinavian Obesity Surgery Registry was published. This includes more than 65,000 patients, and 18% of them were type 2 diabetes. Now, again, when you compare those who didn't have diabetes before the operation, you see that the mortality rate is very, very low. So you won't expect to see in the non-diabetic patient difference in mortality compared to the non-operated patients. So if we compare now the non-diabetic to diabetic study, and in this study they compare it, okay, this is the laparoscopic gastric band study, again, what I showed you before. But now we can compare, like we did, the non-diabetic patient to the diabetic patient. And again, after 20 years, you can see the separation of the lines, but it's still not significant. And of course, after 4.2 years, you won't expect to see difference in the non-diabetic patient. But if you compare the diabetic patient, you clearly see that the separation is from the beginning. Those who had surgery had much less mortality compared to those diabetic patients who didn't have surgery. So again, in line with what we showed you before, okay, the effect of reduced mortality is mainly very early in the diabetic patient and much later in the non-diabetic patient. This is one point. The second point is that laparoscopic gastric banding in this study is in line with our study. Again, we found that even in the non-diabetic patient, the lap is effective in reducing mortality even in a non-diabetic patient. And we can see here in this study that it's in line with what we found. The second point is why survival advantage was greater among diabetic subjects than non-diabetic subjects is the age effect. As you recall, in the diabetic group in our study, there was 10 years difference between the diabetic and non-diabetic. And again, from the laparoscopic gastric band study, we can see here that if you divide the cohort according to the age below 42 years and above 42 years, you won't expect to find difference below 42 years, and you would expect to find difference above 42 years. And again, this is in line with what we found, and maybe the age difference can explain the results. As we see here, in the diabetic patient, there were 10 years difference between diabetic and non-diabetic, and if you cut the line before the age of 42, you won't expect to get the results very early after 4.2 years, only in above 42 years and in a diabetic patient. The limitation of the study is the ability to compare between surgery type. We didn't compare the surgery type for each other. The relative shorter follow-up duration in the sleeve gastrectomy, it was 2.9 years. Lack of severity of diabetes, as we recall, this is a very early diabetes, and maybe the effect is important in the early years of diabetes, most probably. The lack of cause of specific mortality data, and the non-experimental nature of the study, and the lack of information regarding the non-surgical treatment may have biased the results. This is always true in retrospective studies. So our key points is that bariatric surgery was associated with reduced mortality among diabetic and non-diabetic subjects. The survival advantage was greater among diabetic subjects than non-diabetic subjects, however. So among diabetic subjects, the survival advantage was preserved for the 3 types of surgery performed. All the surgery showed the survival advantages in diabetic patients. And among the non-diabetic subjects, significant results were demonstrated only following laparoscopic bending. And to conclude, I want to suggest that acknowledging the effect of bariatric surgery on metabolic status and mortality, people with obesity and type 2 diabetes mellitus should be prioritized for metabolic surgeries. By saying so, I want to thank you for your listening. Thank you. We don't hear you, Professor Min.
Okay, thank you, Dr. Dicker and Dr. Regis for the wonderful presentation. And of course, it's a very interesting study. Really enjoyed it and then learning a lot from you and from your presentation. So before Q&A sessions, I think audience participant, please type in the question box as the secretary has already posted in the chat box for any things you would like to ask the authors. Before that, shall we post some more polls? Okay, can we see the, okay, so the poll result, most of the participants 0% sleep strategy and bypass, only 27% have done the bending, and 33% of the participants have done the BPDDS, and 33% have other procedures. It's interesting. Okay, there's a one more poll, I think. Is it the same one or?
No, I think this is for diabetic
Different
patients.
one. Obese diabetic patients, yeah. Okay, most will do Roux-en-Y gastric bypass for obese diabetes patients. 81% will do Roux-en-Y, 35% will do sleeve, only 3% will do bending, and 90% do BPDDS, and 29% doing other procedures. Thanks all of you for the participation in the poll. So while waiting for the Q&A from the audience, I have some question for Dr. Dicker and Dr. Regis. So Dr. Dicker, in your paper, there was a finding of 2.7% of mortality in the lap bending and RGB compared to 1.5% for sleeve in diabetes group. However, in non-diabetes group, the lap bending group mortality is higher, about 1.5%, if I remember correctly, compared to the RGB and sleeve, which is about 0.5 and 0.4% respectively. Can I ask your opinion on these findings?
So you mean that I didn't hear well the question, Dr. Min, that you mean that in the lap band there was higher percentage of mortality compared to Roux-en-Y and sleeve? That's what you asked?
There's 2.7% mortality in lap bending and the RGB compared to 1.5% in sleeve in diabetes group, right? In the findings.
Yeah. So as we mentioned in the limitation, we did not compare the group of surgery. So the study was built like this, that every surgery is standalone. So we cannot compare the results of one study to another study. This is one of the limitations.
Sure.
So we can't really answer on this.
Sure. Okay. Thanks. Thank you very much. Dr. Regis, do you have any comment, or is same as Dr. Dicker? Okay. Then so far no question from the participant yet.
Yeah, I have to say regarding the two poll questions that the landscape of the bariatric surgery in Israel is changing because now we have more than 50%. It's nearly reaching 60% that we do one anastomotic bypass. And the sleeve, which was more than 70%, is reduced to only 30% now. So this is the change of landscape of bariatric surgery in Israel, and of course that we are preferring to operate one of the two options of bypass, one anastomosis or Roux-en-Y for the diabetic patient.
Okay, so I have some questions. Dr. Philip Greenland says it's an outstanding presentation and very clear. Thank you very much, Dr. Dicker. And Dr. Mato Faleto has asked, do you think the advantage related to the gastric bending depends also on the different number of procedures, more bending than the sleeve gastrotomy and RGB? Do you like to address these questions?
Yeah, so again, we can't really compare between the operation. I think the main issue is the follow-up time. So in the beginning of the time, okay, between the 2005, the band was very popular, of course, and we did much more band than other operation. So we have nearly 7 years of follow-up in band and only 2.9% follow-up in the sleeve. So I think it's very wrong and very difficult to compare. But as long as you have longer time, you can get better results. So that's one of the reasons why band may be show advantage in mortality. The second thing is that most of the band were done in one center in Israel, and the follow-up in this center was outstanding. So I think this is also very important, how you follow up the patients after the procedures, and this maybe contribute to the excellent results with band on mortality. Maybe Dr. Regis want to comment on this.
I think I agree that basically we cannot compare between the types of surgeries. So I think if we want to answer this question, we have to design a study that allowed us to compare between the type of surgery and make sure that we can answer this question. So I think this is the most what we can do in order to answer this question, to design a study that enable us to do it.
Maybe next paper.
Yes.
Thank you. Okay, Dr. Michael has asked both obesity and diabetes are directly linked to a higher incidence of cancer. Have you ever looked at the effect of surgery on cancer as a cause of mortality? Thank you.
So we didn't have the results or the death cause. It was very difficult to get them. But in another study that we have done, we have seen that the results are not due to cancer. But this is, I can't really relate to the results to this study. The answer is that we don't have the death results, so I can't really answer on if it's cancer or not.
Sure. Thank you. So Dr. Hambato has commented, in statistics point of view, viewpoint, the descent in the mortality percentage is associated to the lowering in BMI. Then it must be pointed out in the study. Any comment on that, Dr. Dicker and Dr. Regis?
Ola, do you want to answer or question? Is BMI responsible for reduction of death? This is the question, right? If the reduction of weight is responsible for reduction of mortality.
So I think it could be like the reason that the mortality may be associated with everything that's related to the procedure. So I think it could be one of the explanation. But still, when we compare those with diabetes and those with diabetes to those, and we see the result among diabetes patient and in individual without diabetes, we see there is a difference between these groups. So yes, I think one of the reasons for the lower mortality among non-surgical patients is the fact that they lose weight, and maybe it's related to other reduction in other cardiovascular risk as well.
Yeah.
So yeah, I agree.
I agree. The remark here is absolutely right. I totally agree that the reduction in weight is one of the major, if not the major, explanation for reduction of mortality. And if we didn't mention it, we should. It's true.
It's some preventive effect as well for the for the survival benefit.
Yeah.
Okay.
Yeah.
So another question from Dr. Mahasha. Say, what could be the reason for less effective long-term survival for non-diabetics? Any comment on that, Dr. Dicker and Dr. Regis?
Yeah. So diabetic patients are much more sick patients. So they are older, as we saw, and they have much more. If you look in the baseline characteristics, if you look on this, they have much more complication, much higher cardiovascular disease and much higher kidney disease compared to the non. So if you are much sicker patient, the effect is much earlier. So if you are young and you don't have a disease, so the mortality appear much later, or the effect on mortality will appear much later. In contrast, in diabetic patient, they are older and they are much sicker, and then the effect on mortality become much evident and much earlier. So this is the difference. That's why, to my humble opinion, they should be prioritized, and they also have to be prioritized very early in the disease of diabetes. As we showed here, our cohort was very early in the disease, only 4.5 years in diabetes, and it's really at the time of disease, because the Clalit Health Service and the data warehouse is very particular and meticulous, and we find the patients very early. And if you intervene in this part of the disease, you can really change the course of the disease. The Swedish registry that I mentioned, and from the Carl LaRue paper, excellent paper, so they claim the same thing. If you intervene early enough even in the stage of pre-diabetes, you can really affect and change the course of disease. So I think the answer is that diabetic patients are much more sick patients.
Thank you, Dr. Zicker. So there's one more question from Dr. Hambato. What about SADIs? I think single anastomosis duodenal ileal switch, I presume he's referring to in the lowering of the mortality. Your paper doesn't, no, we don't have, right? SADIs. Upon your literature review, do you have anything to comment?
No, I didn't look for the literature because we don't do such a surgery in Israel. To my best of the knowledge, we don't do SADI in Israel.
Okay, sure. I think one more last question. I think, let me see. Okay. So the last question from Dr. Andres is that based on your results, which diabetic patients would you prioritize for bariatric metabolic surgery from now on? So with your study outcomes and then your findings, what will your comment on that? Yeah.
I think every diabetic patient will benefit from metabolic surgery. As I said before, the sooner, the better. So to my humble opinion, every diabetic patient will really earn and have a benefit for metabolic surgery. Of course, if they are fit to go with the surgery. So if you wait too long and they have severe heart failure and severe complication, so then, of course, the surgery is in higher risk. But every diabetic patient that are willing to change his life is candidate for metabolic surgery.
Yeah, absolutely. Yeah. So before it is too late, right? And then before the diabetes become more harming to the body, we should consider the surgery as the solutions to help those patients to prolong with the better survival benefit. Yeah. Thank you very much. Yeah,
thank you.
So I think
I want to thank all the co-author for an excellent job, because it wasn't so simple. Data mining is not so simple, and I want to acknowledge and thanks Dr. Regis and all the other author for an excellent cooperation and excellent job. So thank you.
Thank you very much. Yeah, it's very interesting, and then also the look at the Xxiii has a very good data warehouse to extract the data, and then also to look into these outcomes measures. Is really interesting, and then I think probably looking forward to some more papers from you and your co-authors as well, and looking forward to the future publication from your center. Yeah.
Okay.
So
thank you very much to you and to Ifso.
Thank you. Yeah, really enjoy listening to your talk. Yeah, so I think now is a time for us to call for the day. So thanks all authors, as well as all the participants for joining us today. I would like to see all of you in person in the future Ifso events in the very near future. Hopefully, pandemic will be over soon with the vaccines on the way. And also would like to cordially invite for all of you to join Ifso if you're not Ifso member yet. So please take care and stay safe, everyone. Have a good day, everyone. Bye bye.
Thank you.
Thank you very much.
Bye bye.
Bye.